Hi, I'm Annie O'Leary. I'm a Band 7 Neuro-OT at Worthing Hospital, and I've been asked to just create a short film today about cognitive assessment of stroke patients and also what to consider with regard to new cognitive problems when planning a safe discharge for stroke patients. I will be needing to look at my notes because I haven't had much time to prepare for this. Around 2/3 of patients may experience cognitive impairment post-stroke, so that's quite a lot of them, and that's why this is very important to assess most patients. Sometimes there's a belief that if somebody has a new cognitive impairment post-stroke, then it's part of a steady decline. But actually, around 20% of patients with cognitive impairment after stroke can improve. Most of the improvements happen in the first 3 months, but recovery can continue up to a year post-stroke. It's important to know this information because very often family will ask, are these problems going to be there forever? And it's good just to have a little bit of information to pass on to the family. Most of the patients that you'll see immediately after a stroke will present with some degree of cognitive impairment, and it can be even for people without limb weakness, which is one of the reasons why screening of all patients is important. We use the MOCA as our general standardised screen for non-aphasic patients. And we use the but non-verbal test for aphasic patients. We also have a cognitive flowchart which outlines the different options for cognitive assessment for people with visual or hearing impairments, or people presenting with other specific problems. It's also important to note that standardised cognitive assessment in itself is not enough, and that a lot of the time we will need to complete functional assessments as well to have a look at the kind of problems that people might be presenting with. The reason why it's so important to pick up on new problems post-stroke is to make sure that people are getting the right amount of support with their basic ADLs, but also specifically with their higher level ADLs, and those are often the areas that we're really concerned about. So things like banking, dealing with their post and their correspondence, dealing with problems that might crop up, dealing with managing changes in their medications, and even a slight change in someone's cognition may impact on how well they can manage those areas. So the first assessment that will always be done with the new stroke patient is the NeuroTriage, and some degree of cognitive assessment can be done within the NeuroTriage. You are looking at whether the person's orientated, do they have insight into their new problems, are they aware they've had a stroke and how it's affected them, are they able to attend to the assessment, can they concentrate, are they overly distracted by things going on around them, do they remember they're in hospital and what's happening if you pop back and see them later in the day, do they remember you from earlier, do they remember they've had a stroke, anything like that. So it's really just being observant as to all those areas of cognition when you're first seeing the patient. It's absolutely essential to gain a full history of cognition from the family and from the patient, and then it's really interesting to look at discrepancies between the two. You want to know about their normal cognitive function, because obviously if they normally have problems with their memory, then you're not going to be expecting them to be performing amazingly in hospital. But if they are normally treasurer of the golf club or they're working full-time, you can presume that their cognitive function is going to be pretty good. So you need to ask a lot of questions about the specifics of their normal cognitive function. You're wanting to know, do you manage your own money? Do you manage your own banking? Do you manage your own medications? Are you able to cook a meal from scratch? Things like that, to get an idea of what their attention and their executive functioning is normally like. So all patients require a standardised cognitive assessment after stroke. As I said earlier, normally we complete the MOCA, but it's really important to remember that the score of any standardised assessment is only part of the picture. there may be other elements that impact on their score. You need to relate it to their previous level, kind of as I was just saying. So if somebody normally has a memory impairment, but they manage really well with that at home with using calendars and diaries and writing things down, then perhaps their score 0 out of 5 on the memory section of the mocker, but that's fine because they've got those strategies in place and you're pretty confident that they're going to be able to manage that, and that's normal for them. It's important to consider in hospital how lots of the environmental factors will impact on somebody's cognition and that perhaps impact on their cognitive assessment score. They're likely to have not had much sleep, especially if they come in during the night. They might be very anxious and stressed, they might be in pain, and all of these things can impact on somebody's cognition. It's worth reminding people of that sometimes if they're particularly upset by how badly they've done on an assessment, but also not to discount the score if it is bad and think, oh, it's just because of those things, but it's just important to note. Also environmentally, for somebody that relies on lots of strategies in their home environment and has a pre-existing memory problem, that is also going to impact on their score in standardised assessment. It's important to pay close attention to how somebody completes it, not just what the score is. So how well they concentrate, do they need the instructions repeated, how quickly are they able to do it? So you kind of look at how they go about it as well as what the score is. If somebody is normally, say for example, an elderly person who is retired and they live with their partner who does all of the banking and kind of helps manage their medications, and they kind of do their normal activities and they're scoring just a bit below 26, it's not really much of a concern. But if you have somebody who's working full-time as a teacher normally and they score even actually at 26, if they're scoring anything lower than 30 sometimes, maybe that's an area to be concerned about. So the score and the cut-off point isn't the thing to think about, it's what the problems are that the person's having and how they would compare to what they normally do. So coming on to functional assessment, it's important for all patients post-stroke. You don't need to do a functional assessment with everybody. It might be that you see somebody, you do the NeuroTriage with them, they seem really great, they've just got an upper limb weakness, you do a mocker, they score fine on the mocker, and no concerns have been raised by the nurses, they've been out to the bathroom, they've had a wash and they've got dressed, and you feel that a functional assessment is not indicated. Absolutely fine. There's one group of patients I'd say it's really important to complete at least some functional assessment for, and that's aphasic patients, partly because it's often difficult to complete the standardised cognitive assessment with them, but also because patients who have aphasia very often also present with apraxia. The two will often come hand in hand, and apraxia is a disorder of skilled motor movements, and it will often really impact on somebody's safety. So the kind of problems that you may see with apraxia are performance errors and object use errors. So for example, somebody might wash their face with a dry flannel, or they might try and wash their body before they've taken their shirt off. They might put deodorant on their face or try and brush their hair with a toothbrush. In the kitchen, you will often see problems like somebody filling the mug rather than the kettle from the tap, or putting the tea bag straight in the kettle. Quite often these problems are, they may be harmless and somebody may figure out that they're having a problem and then correct it, but sometimes they can really impact on somebody's safety and also impact on their independence. So it's important to look out for any errors like that, especially for patients who are aphasic. Within the functional assessment, really pay attention, do they need prompting to attend and sequence? Are they likely to need prompting at home? Are they needing help to plan and problem solve? Is this likely to mean that they'll need care on discharge? A lot of our patients live alone, and that can make the discharge planning kind of decision about whether they'll be safe more complex. So we're thinking about patients who are normally cognitively intact, come in, had a stroke and have a new cognitive impairment, it's important to know whether they can use a call bell. We will provide those patients with care line alarms, but will they understand what it is? Are they able to use it? Do they understand when they need to use it? So it's thinking about those kind of things and whether the patient would be safe to be left alone. Because the problems are new after a stroke, somebody hasn't got steadily used to having the problem, they've been absolutely fine, and then suddenly they've got a new problem. Insight can often be a difficulty. So if somebody is not safe to walk by themselves, and you're saying you need to walk with one person, you need to wait till the carers come, it may be that they're not remembering that, or that they don't have the insight to follow that advice. So the kind of safety questions you can ask would be things like, what would you do if you fell over? You'd want them to say, use the call bell. What would you do if you smelt smoke? What would you do if you wanted to have a cup of tea and the carers weren't there, for somebody who needs to be waiting for the carers to be safe to walking? We've got a list of safety questions in NeuroT, and I'll put them on the drive somewhere where people can access them. So kind of intervention, there's obviously not going to be much time for much intervention, and a lot of it's going to be signposting and giving advice to people, providing advice to the patient and to the family over the telephone, signposting them to the Headway and the Stroke Association websites, where there's loads of great leaflets about different types of cognitive problems post-stroke. Provide them some basic advice on strategies, things like writing things down, things like making sure there's not too many distractions around if you're trying to concentrate on things. And something that I will always do for anybody that is possibly got some new cognitive problems post-stroke, but possibly it might be just that they're a bit overloaded and tired, and you're not sure, and they've not done great on the mocker, but they seem okay. We'll always refer those patients on for follow-up in the community, but I will always ask them to make a note once they're home and say, go back to doing your normal things, go back to doing your normal cooking, your normal banking, but note down if you're having any problems. If you're making errors that you wouldn't normally make, if you're forgetting things you'd normally remember, if you're finding it more difficult to concentrate when you're reading a book or doing your crossword, then just make a note of those things so that when you speak to the community therapists, you can say what the issues are and they can give you further help with that. One more thing on the bottom there is just if there is any concerns about how it's going to impact on somebody's function and you think they're going to need extra care, then obviously refer them to the discharge hub for care. Oh, I flicked through that too quickly, but all of our stroke patients are referred on to CNRT on discharge, which is the Community Neuro Rehab Team. It's a bit of a complicated procedure of how to do that, and I think but all of the neurotherapists know how to refer on to Community Neuro Rehab Team. So that's physios, speech therapists and OTs. Just wait till one of them is around, ask them, and they can help you complete that referral onto Community Neuro Rehab Team. Thank you.